Good evening. Why don't we go ahead and get started on time? I'll be very brief, but my name is Evan Davis. I'm one of the administrators here at Memorial. Just wanted to take a moment to thank you for coming and welcome you to Wetterberg Conference Center this evening. I can tell you we're in store for a great talk by two orthopedic experts with the Springfield Clinic Orthopedic Group. They're behind the pillar, but Dr. Ma and Dr. Greeting, who is going to come around the pillar, and there he is. They are both orthopedic surgeons, board certified, also both fellowship trained in the upper extremity, or the hand and shoulder, elbow, etc. And what that means is they are a highly specialized group amongst orthopedic surgeons who specialize solely in the hand and upper extremity. So we're very fortunate to have these experts with us. I can tell you they're also very well trained. They won't like me to brag on them like this, but Dr. Ma's fellowship training was from Duke University, and Dr. Greeting was fellowship trained up at Mayo. So you won't find better places to train for this kind of work. So without further ado, let me introduce the first speaker, Dr. Ma.
Thank you. It was a great introduction. Good evening. My name is Dr. Jianjun Ma. I'm a hand and upper extremity specialist at the Department of Orthopedic Surgery in the clinic. Tonight, I'm going to talk about treatment of hand numbness and tingling. Hand numbness and tingling are very, very common in our daily life. We see this type of patients every day. Sometimes they are very confusing. Sometimes the numbness, tingling is a thumb or index finger. Sometimes in a small finger. Sometimes happen at work. Sometimes happen at night. So we know carpal tunnel syndrome and cubital tunnel syndrome are very, very common in patients with hand numbness and tingling. So today we're going to focus on these two problems, carpal tunnel syndrome and cubital tunnel syndrome. So I'm going to start with the case. This is a 40-year-old male who is a professional guitar player. Actually, he's a friend of mine. He has been very, very busy. This happened like 6 months ago. He was very, very busy preparing his new album. And his secretary was diagnosed with carpal tunnel syndrome because of the numbness and tingling in the hand. So he called me. He said, do I have the same problems of carpal tunnel syndrome like my secretary? I'm very, very busy. Can I wait a few more months and then come to your office to get some evaluation or treatment? Then he also asked what kind of treatment I need. So this is, I feel like I think this is a very classic case for this type of problems. This patient is middle-aged. He's in the middle of his career, which require, dedicate finger range of motion and the sensation, which is critical for them to expand or maintain their career. Because we saw lots of patients, actually, started with numbness and tingling in the hand, and unfortunately, because the symptoms progressing, they have to change their career. So it could be devastating for the career. So before we talk about this case, we can let's talk about more for the hand numbness and tingling. So we know hand numbness and tingling is associated with some problem with the nerve. We know this. This is not from the broken bone or from ruptured tendon. We know this is from the nerve. There are two types of nervous system in our body. One is central nervous system. One is peripheral nervous system. Central nervous system, you can see from here. Actually, this central nervous system includes brain. This is brain. This is spinal cord. This is central nervous system. Peripheral nerve system basically is a structure connects the central nervous system to the other part of the body. For example, to your hand or to your feet, to our feet, such as an sciatic nerve, connect our spinal cord to our feet. Peripheral nerve is critical to for communication between the brain and our fingertip. For example, if we feel something with our finger, say if it's hot, at that time, some receptors in our skin, in the fingertip, will send a signal through the peripheral nerve. You can see from this picture here. From here, send a signal through the peripheral nerve to our brain, so our brain knows, oh, this is hot, this is cold. Then our brain will send a signal through the motor nerve fibers in the peripheral nerve to the hand, so we can flex our finger or extend our finger. So we know peripheral nerves is very critical to maintain the communication between our central nervous system and other parts of the hand. Hand numbness basically is like a type of partial loss of the sensation. If you say my finger's numb, that means you cannot feel something sharp, feels like blunt. You cannot feel like texture of something. Tingling is like sort of like a sensation of like a pin or needles in your skin, and they are very, very uncomfortable. Usually it's like it's related to peripheral nerve dysfunction. Very, very common is actually from nerve compression or from pinched peripheral nerve. So when we talk about the peripheral nerve, we have to talk about some fibers inside the peripheral nerve. We know the peripheral nerve in our body like an electronic cable which connects power plant to our house. Because this cable, we can use electricity in our house. In peripheral nerve, there are 3 types of nerve fiber inside this cable. Sensory nerve fibers are responsible for sensation. So every time you feel something, these are relate to sensory nerve fibers. Motor fibers are responsible for muscle strength and muscle contraction. The third ones we call autonomic fibers, which are responsible for involuntary activity, for example, for sweating. Say, if sometimes if the patient has some compromise of this type, say, to autonomic nerve fibers, say, for example, in diabetic patient, they always complain, hey, my finger, my hand, very dry. We don't know why. Actually, it's because the autonomic nerve fibers are destroyed. In this case, they cannot sweat. So that's why complaining some dryness in the hand. The same thing here. If you have anything injury to the sensory fiber, you're going to have some sensation issue. For example, you have numbness, tingling. If you have some motor fiber, for some injury associated with the motor fibers, you're going to have some muscle atrophy. So let's talk about the histology of the peripheral nerve. Histology is a study we have been using to look at the tiny structure inside the nerve, such as cell or stuff. Usually we cut the tissue to a very thin slice, then do some staining. Then we use our microscope or electron microscopy to look at the structures. So this is this has involved a great deal over the past 100 years. About 100 years ago, people looked at this structure with our eye, and later on, I think it's 1930, we invented electron microscopy, so we can see this very tiny structure inside the nerve. For example, this is the ulnar nerve in the operating room, we can see this with our naked eye. See the nerve has a diameter of like 4 millimeters. You can see this. This is a view under the operating microscope. You can see some small vessel actually here. You can see this vessel here on the nerve. Then this is also the view under operating microscope. This nerve was lacerated, was cut accidentally. You can see some axon they stick out from the end of the nerve. These are nerve bundles, which are composed of lots of nerve fibers, including motor and sensory nerve. To be able to see the small structure inside the nerve, as I just mentioned, we have to cut the tissue to very small, very thin slice and then do the staining. Then with a microscope, we call optical microscope. Then we look at the inside the nerve. So this is a side view of the nerve. Basically, we cut the nerve like this, from this, longitudinally cut the nerve, and do the staining. So you can see this is a nerve fiber. This is one nerve fiber, this is another fiber. Then if we do cross-section, like I say, we just cut the nerve like this, and we can see the view from here. You see a lot of circle here. All these circles are staining of the cover sheath of each nerve fiber. So we know lots of nerve fiber here. Every circle has one nerve fiber. And also some nerve that do not have the covering sheath. That means, here a lots of nerve was not stained here, but you already saw lots of nerve fiber here. So this is very different. Under microscope, this is the structure is very different from what we saw from our naked eye. So to be able to see even detailed structure, sometimes we have to cut the nerve with some special technique and do some special staining. Then we can look at the structure with the electron microscopy, which has been used for like past 80 years. So look at this is a very different structure from this one, and this is the one of look at the marker. This is like 10 micron. This is a 50 micron. Actually, this is one of the nerve fiber. This is probably about 1/10 of our hair. So this is extremely, extremely small. Understanding of the histology of this structure is very, very important for us, for the diagnosis, for the treatment, and also for the prognosis. So for the peripheral nerve injury, this is very common because they are fragile, very easy damaged, and we know every nerve has a path from a spinal cord to the hand or to the feet. We know anywhere from the spinal cord to the other part of the body, anywhere on the course can be pinched. It's interesting, sometimes the nerve can be pinched in different area. And a very common, sometimes also can see one place pinched and make other place even more susceptible to be compressed. We call double crash syndrome. We know sensory nerve fiber usually is very small and very susceptible to nerve compression. And motor fibers are very large. They can tolerate the compression relatively well. You can see from this picture, usually this is motor nerve fibers. And this is probably small, this is sensory nerve fibers. So this histology tells us why the patient will complain, say, hey, I have some numbness as the first symptoms, because the sensory nerves is most susceptible to nerve compression. So that's why patients say, oh yeah, I always have numbness, tingling in the beginning, then in 6 months or a year, then finally I have some weakness, I have some muscle atrophy. So always start with a sensation problem, then gradually, both motor and sensory involved. That's like an important characteristic of the nerve compression. In other words, if the patient say, hey, doc, I have muscle weakness or muscle atrophy first, I do not have any sensation problem, then I can say probably you do not have nerve compression. You might have some problems from your spinal cord or your brain. These are very different. So every time if you see any patient with this compression or pinching nerve, they always start with the sensation problems. So in terms of timing of the injury, most of the time we see the patient have like acute injury, trauma, or chronic nerve injury. For acute injury, we can see sometime, in the ED, they have some nerve was cut by some knife or accident. Usually the patient will present with an immediate sensation loss. They cannot feel anything in the hand. No numbness, tingling. They just cannot feel anything. No matter what they do, you can use a needle, poke their finger, they don't feel anything. Then subsequently, they will have muscle atrophy quickly. This is acute nerve injury. For chronic nerve injury we call compression. Actually, compression is very, very common in chronic nerve injury. And chronic nerve injury is way, way more common than acute nerve injury. And nerve compression is a chronic process. In the beginning, patient always complains some numbness, tingling. They will never complain, hey, suddenly, overnight, I cannot feel anything. I lost the sensation 100%. No, this is not nerve compression. Nerve compression always have some numbness, tingling in the beginning, then gradually, when the symptoms keep progressing, they develop some sensation loss and a severe muscle atrophy later on. So this is a different process. So in terms of the severity of nerve injury, there's some classification. Very interesting in the clinic. Lots of time patients ask us, hey, I had some nerve study done where, and the doctor explained to me, hey, you have severe nerve compression, or you have a mild nerve compression. So the patient asked me, explain to me, what is severe nerve compression? What is mild nerve compression? So it's very confusing. So there's some physiological evidence behind this classification. For mild nerve injury, the structure usually is still intact, but the nerve just cannot function to deliver the signal to the brain or to the hand. But the structure is okay. So when you do so at this time the patient will complain some numbness, tingling, but they do not have muscle atrophy. They do not have any sign of the nerve compression, but they have symptoms. If the symptoms keep progressing, some structure, the covering of the nerve fiber, as I just showed you on the slides, actually start to degrade. You can see these structures start to degrade. At this time, the patient will complain some symptoms, and also they will present with some signs, like with weakness or clumsiness of the hand. If the symptoms keep progressing again, they can develop we call severe nerve compression. At this time, the structure, actually, the integrity of the structure is disrupted. You can see from here, the continuity of the nerve fibers disrupted. This time, the patient will say, I have severe numbness, tingling, and or sometimes they could not feel anything. They lost the sensation 100%, and they have severe muscle atrophy or wasting. So from this classification and the evidence of physiology and histology, most of the time we will encourage the patient come to see us at this stage, mild stage. At this time, the structure is still intact. We can treat this type of compression with non-surgical treatment. For example, with activity modification, with a splint, with a steroid injection. the patient at this stage, they do great. They will do very well. They can 100% recover. For some reason, the patient say, I was too busy, I cannot have any chance to get evaluated. If their symptoms keep progressing to moderate, then this time it could be could be problematic, because we still offer some non-surgical treatment, but we have to monitor very closely, because sometimes they do not respond to surgical treatment. This time we have to treat them with surgery. But if to this stage, to a severe degree, basically we discourage the patient come to this stage. Because at this stage, the patient usually will need surgery. But even with surgery, the recovery sometimes is not good, because the patient usually have some pain. Even after surgery, they will have some relief, but still the pain will not go away 100%. The muscle wasting, muscle atrophy in the hand, once this happens, but they rarely can be restored. So this degree, if it's severe injury, patient will not do well. So we always encourage the patient, come to see us, get evaluation. We can treat it early. We can address the problem in a milder stage, or at most moderate stage. Usually the patient will do very, very well at these two. If the patient comes to our clinic too late and in severe stage, then usually they will not do well. So let's talk about sensation in the hand before we go detail for the carpal tunnel syndrome and the cubital tunnel syndrome. So there are 5 major nerves in our upper extremity. Among these 5, there are 3 major nerves. One is median nerve, one is ulnar nerve, one is radial nerve. They contribute to the sensation in the hand. The other 2 nerves, one is for the shoulder, the other one for the elbow. They do little or nothing to the sensation in the hand. So for the median nerve, median nerve is responsible for sensation for these 3 fingers: thumb, index, long, and half of the ring finger. For the ulnar nerve is responsible for the small finger and half of the ring finger. For the radial nerve, you can see only for the back side of the hand. You can see from this picture, you can see here, this is median nerve innervation area. This is sensory nerve innervation area. And on the back side of the hand, you can see this is radial nerve innervation area. So this is extremely important. If, say, the patient complains of numbness tingling here, then I will say, okay, you probably have the problem with the median nerve. You don't have the problem with the ulnar nerve. If the patient say, hey, I have numbness tingling here, then I will say, okay, you probably have the problem with the ulnar nerve. It's not from median nerve. So these are very, very important information for us to evaluate the hand numbness and tingling. There are lots of nerve compression syndromes associated with the hand numbness and tingling. And we know we have 3 major nerves contribute to sensation in the hand. For the median nerve, there are 3 types of syndrome: carpal tunnel syndrome, pronator syndrome, anterior interosseous syndrome. For the ulnar nerve, there are 2 types. One is cubital tunnel syndrome, one is Guillen's canal syndrome. For the radial nerve, there are three syndromes. One is radial tunnel syndrome, one is posterior interosseous syndrome, one is superficial radial nerve syndrome. Among these 8 syndromes, carpal tunnel syndrome is most common, and the cubital tunnel is second most common. I have to say, if the patient has numbness in the tingling in the hand, if it's related to nerve compression, probably 90% of these problems are related to carpal tunnel syndrome or cubital tunnel syndrome. So understanding cubital tunnel syndrome and cubital tunnel syndrome are very critical for us to deal with hand numbness and tingling. Before we address the cubital tunnel syndrome and carpal tunnel syndrome, we have to address some systemic disease, because these systemic diseases make the patient more susceptible to nerve compression, and they should be managed by medicine. Number one is diabetes. Diabetes can cause nerve terminal degenerate, we call diabetic neuropathy. Thyroid disease, collagen vascular disease, we also call vascular disease, annitis, like rheumatoid arthritis, lupus, multiple sclerosis. And it's interesting, chemotherapy-induced neuropathy also is not rare. Over the past few years, we saw probably 10 cases at least probably every year. Say the patient has breast cancer, they had the radiation therapy, and in 5 or 6 months later, they developed some numbness and tingling in the hand. So what's surprising, this is actually not rare in hand numbness and tingling. Alcoholism, vitamin deficiency, and also some heavy metal toxicity, Lyme disease, multiple myeloma, and AIDS. So when we we evaluate the patient with the hand numbness and tingling, we have to consider all this common disease. So we know in upper extremity, every time we try to move our finger to grab something, to feel something, to touch something, we always need some range of motion in the wrist, in the elbow, Unfortunately, too much motion or excessive motion or pressure in either wrist or elbow can cause a problem to the finger, make the finger unhappy because they're numb or tingling. And, they say, you help me a great deal to help me grab something, and also you make me suffer because I have numbness, tingling, because you too much range of motion in the wrist and the elbow. So they are connecting together. It's not separate. And we know carpal tunnel syndrome is the most common, involved hand numbness and tingling. So let's talk about carpal tunnel syndrome. So carpal tunnel syndrome is very, very common. There are 1, 2, 3 new cases added to our population. About every 1,000 people, you will have 1, 2, 3 new patients with the carpal tunnel syndrome every year. And in general population, we have 5%. This is pretty high. But in some conditions, this could be even higher. For example, in patients with diabetes, this could be 14%. If the patient with diabetes also suffering neuropathy, this could be 30%. Also, in some occupation with a repetitive motion, sometimes it could be even 40 or 50%. This is very, very high, very common in our daily life. And unfortunately, female, they are 3 times more likely to suffer carpal tunnel syndrome than male. I guess they work too hard at home, and I think every husband, you understand that. Also, the dominant hand is usually first affected. Overall, about 10% of all of us will suffer carpal tunnel syndrome in our lifetime. So what is the carpal tunnel? Because every day people say carpal tunnel syndrome, carpal tunnel syndrome. When we ask what is carpal tunnel syndrome, actually, some people say, I know the name, I do not know what is this. So carpal tunnel basically is a very narrow passageway on the palm side of the wrist. And it's made up of the bone, tendon, and a ligament. So this is the carpal tunnel, the green one. So here, this is the carpal bone. And also you see some ligaments between the bone and the tendon. And the size of the carpal tunnel actually is very small. It's much smaller than most people thought. This is about 135 square millimeter. That means this is smaller than my thumb. It's very, very small. And there are three types of structures inside this tunnel. There's one nerve we call median nerve. There are 9 tendons. There are flex tendon, and also some synovium inside this tunnel. At this level, the size of median nerve is very small. It's about 10 square millimeter. That means this is about like a circle with a diameter of 3 millimeters. But interesting, even with this small structure, there are about 7,000 to 20,000 of nerve fiber in that small area. So you can imagine the nerve fiber is very, very, very small. And they are very fragile with the trauma. So that's why, when you excessively move your wrist, or your wrist experienced constant pressure, the tunnel can be inflamed, some inflammation around the structure of the tunnel. The fundamental mechanism of carpal tunnel syndrome is increased pressure inside this tunnel. Then can compress, the pressure is high in this tunnel, then they can squeeze the median nerve. When they squeeze the median nerve, as I just mentioned to you, these fibers, the motor fiber, the sensory fiber, the autonomic fibers, they cannot function well. Then the patient will present some numbness, some weakness, some too much sweating or dryness, all these symptoms. These symptoms we call carpal tunnel syndrome. So we know the carpal tunnel syndrome is a group of symptoms from the pressure on the median nerve, from whatever the reason. So let's talk about the symptoms of the carpal tunnel syndrome. Most common, patient will complain some numbness, tingling in the index and the middle finger. And this is followed by the thumb. Very rarely, the patient will complain and say, hey, I have numbness in my ring finger. So these two fingers are very, very common to have problems in carpal tunnel syndrome. Patient very often will complain sometimes they have to wake up several times. Sometimes they say, hey, I have to shake my hand several times. I cannot sleep well. I have numbness and tingling in these two fingers. These two symptoms are very important for us to diagnose carpal tunnel syndrome. There are some mechanism, some explanations say why patient complains some numbness, tingling at night. We don't know exact mechanism, but at least one, because in our forearm we have flexor on this side muscle. We also have extensor on this side. The flexor, this is much stronger than the extensor. When we are in sleep, everything's relaxed, so automatically the flexor will pull the wrist into flexion like this. And it's very common people will sleep with a wrist inflection. If your wrist has an inflammation, in this situation, you will have some numbness and tingling. So that's why patient can be treated with a brace to prevent the flexion to treat the carpal tunnel syndrome. Thinner muscle wasting. Thinner muscle is the muscle around the thumb. If sometimes the carpal tunnel syndrome patient, they'll complain, say, hey, I have some numbness in the finger, also have some numbness have some muscle atrophy in the thumb. This is very classic, but it's very rare, especially today because education from internet, from media, people know what is carpal tunnel syndrome. They can be managed very, very well. But sometimes, occasionally, we still saw some patients from nursing home. They did not have like an early evaluation for over prolonged time. They can present with a severe muscle atrophy around the thumb. Patient also complains some weakness in the hand. They also complain, say, hey, I cannot grab some little thing, and my hand keep dropping small items. There's two reasons. One is because they have numbness and tingling. They cannot feel the small objects. The other one, they also have some weakness. Because of these two reasons, so patient pretty common say, hey, recently, I cannot hold the little stuff. And I didn't realize I already dropped the small things for 3 times. I didn't realize. So these 4 symptoms are very common in the patient with the carpal tunnel syndrome. So how to diagnose carpal tunnel syndrome? I think history is very, very important. We know the pattern of the numbness tingling. Patient usually complains of numbness in the tingling in the index finger and the middle finger, sometimes in the thumb. And the timing of the symptoms is very, very important. The patient will say, hey, I have a numbness tingling at night. I have shaken my hand several times. This is very common, very unique for carpal tunnel syndrome. Physical exam also is very important. We know the sensation, a decreased sensation in median nerve distribution. Also some muscle weakness in the thumb. When they move the thumb, the muscle strength is compromised. Tinel signs is very important for us to evaluate the peripheral nerve injury. Usually you can tap at the median nerve area, and you will feel some tingling and numbness in the fingertip. This is positive. You can do like this. Fairness test is another important test. You can bend your wrist as much as you can, then put these 2 together. Then if you have numbness, tingling in these 3 fingers within 1 minute, then usually this is positive. Another test we call Duncan test. You just put the pressure on the median nerve. Then if it's triggering the numbness, tingling in these 2 fingers, you can do both sides. You can compare that. This is positive. So if you have positive sign for all these 3 exams, probably the chance to be diagnosed with carpal tunnel syndrome probably is more than 90%. So to diagnose this carpal tunnel syndrome, I think history and physical exam most of the time will be enough. But sometimes we also order some tests to confirm or to rule out carpal tunnel syndrome. For example, sometimes we order X-ray to rule out arthritis or fracture. For example, in this patient, he suffered distal radius fracture. You can see from here this actually is pinched median nerve. So he has carpal tunnel. He has a distal radius fracture from here. Also, he's complaining some numbness, tingling in his 2 fingers. Sometimes we order an electromyogram. We can put a needle into the muscle. We can measure the electrical discharge in the muscle. Then we can determine if there's any damage in the muscle. Nerve conduction study is very important. We can give some stimulation. Then we can measure the speed of nerve conduction inside the tunnel. Then we can also rule out other nerve issues from the neck. There are some risk factors associated with the carpal tunnel syndrome. some anatomical factors, for example, fracture, dislocation. Female patient usually has very smaller size of the carpal tunnel. Probably this is one of the reasons of why female patient has higher rate of carpal tunnel syndrome. Some nerve damaging conditions such as diabetes and alcoholism, inflammatory conditions, some rheumatoid arthritis, infection, they can affect the tendon and can irritate the nerve. Also, in patients with the altered balance of fluid, for example, for female patient with pregnancy, they have extra fluid in their body and make them susceptible to develop carpal tunnel syndrome. But usually this type of problem can be managed once pregnancy is over. Workplace factor is a big deal. This is a very common, common problem today, for works comp and for our patient. They're using vibrating toes, and all the job requiring prolonged or repetitive flexion of the wrist, which will increase the pressure inside of the carpal tunnel. This is very common. So here's scenarios we will see in our daily life with carpal tunnel syndrome. When we use computer type, I think this is very important for secretary. Make sure your wrist is straight, and do not turn your wrist inside too much. Do not turn your wrist outside too much. Keep the wrist straight here, and do not turn in too much. Do not turn out too much, and do not flex the wrist too much. Do not extend the wrist too much, because all these will increase pressure inside of the tunnel. So at home, at work, make sure you have a right posture. For driving, the driver is advised to wear gloves to relieve the vibration. And for this patient, he did not wear the gloves, and then he put his wrist on the top of the wheel, which will suffer a lots of vibration because of this. And also the wrist is in flexion. So this too will increase the pressure inside of the tunnel. So this patient will be, I think he will have very high risk to develop carpal tunnel syndrome. Playing video games, sometimes they can play 3 or 4 hours without any break. Actually, it's very common, the 20 years old, adolescent come to our clinic and say, "Hey, doc, I have numbness, tingling, I have carpal tunnel syndrome. What happened?" And then we ask him, "Oh, he has been playing video games 3 or 4 hours without any break." Carpal tunnel syndrome is very extensively involved in many occupations. You can see from this list, like a tailor, farmer, assembly line worker, mechanic, gardener, office worker, homemaker, janitor, musician, cashier, carpenter, painter, almost everywhere. So, so this is very common, and the good news is that for carpal tunnel syndrome, we have to say majority of patients, with carpal tunnel syndrome, they can do very well with a non-surgical treatment. That means most of the patients, they do not need surgery for carpal tunnel syndrome. If they can be evaluated early or treated early, they can do well. So we always start with the activity modification. We'll advise the patient, just take a break very frequently. Do not keep typing for 3 hours without any break. Take some non-steroid anti-inflammatory medication such as Motrin, help to control the inflammation. And sometimes, just wear the splint also can relieve the symptoms. The problems with the splint is, I think it's very effective. The problem is the patient say, "Hey, I know splint's helpful, but I cannot do this at work. I cannot wear the splint at work because it's not convenient. That is true. So there's some restriction to wear the splint sometime. I think these three treatments can help lots of patients a good deal. But if these three treatments are not enough, then we can offer steroid injection. Steroid injection, I think, lots of people hate this. Hey, the needle is too long, it will be painful. I'm afraid of this. I always told my patient, it's not pain-free. This is a real needle. But I have to tell you, 99% of patients, they will say, oh, yeah, this is, after the injection, I didn't realize they already inject this. I didn't realize it's so little pain. So I think, people are always more nervous. They sort of like too much pain before the injection. So it's a needle. It's a little painful, but, don't be scared of that. 80% of patients with the carpal tunnel syndrome, they will respond with a steroid injection, 80%. But however, I have to remind you, with the steroid injection, the inflammation will be managed. However, sometimes if the numbness tingling is from the degeneration of the nerve, sometimes I have to say numbness tingling in your hand usually is related to one is from degeneration because the structure change. One is from the inflammation. Steroid injection only controls the inflammation. But for the degeneration, the mining degenerate, steroid is not going to help for that. That's why for the carpal tunnel syndrome patient, the first time injection, they can help for sometimes for a year. Last time I saw a patient, he's a pilot in North Carolina. He said, I need an injection once a year. Every time I drive pilot. So he did very well. But very common, the patient say, first time injection help a year, second time injection help for 6 months, third time injection for like only 2 months. The fourth injection probably only help for a few weeks. So the efficacy of the steroid injection would decline if the compression is not correct. For example, you skip like a typing with a wrist inflection, you still holding phone like this for a long, long time, these symptoms will progress. No matter what you do, you wear brace or corticosteroid injection. But again, steroid injection will help you a great deal in the beginning. But over time, if symptoms keep progressing, the efficacy of the steroid injection will go away. Small percent of our patients, they will need surgery, for multiple reasons. For example, I think we had like a couple of patients, a nurse, they had carpal tunnel syndrome. Then we give some advice, and the patient said, no, I cannot change my occupation. I am doing 2 jobs every week. I just can't do this. Then we offer surgery. So the indication for surgery are basically if you fail to non-surgical treatment and your symptoms keep progressing, you say, hey, I cannot deal with this numbness tingling anymore. Then we can offer surgery. The goal of surgery is to just relieve the pressure of the median nerve. It's simple. You cut the ligament, relieve the pressure. There are 2 types of the procedure performed to relieve the carpal tunnel syndrome. One is open surgery, one is endoscopic surgery. These techniques are evolving a great deal over the past 20 years. I think 20 years ago, endoscopic surgery probably was very popular. But today, we have, I think in this country, data shows that there are about 300,000 carpal tunnel syndrome patients underwent surgery. Probably 90 or 95% patients were managed with open surgery by orthopedic surgery. You know, some surgeons still doing endoscopic release, but it's way, way less than probably 10 or 15 years ago. So with the open surgery, you can see from this picture here, basically we are, right now we are making small incision here, and then we just release the ligament. And you can see this patient, you know, after we release the ligament, you can see the nerve, some compression, a dent here. You can see this area basically is very flat from chronic compression. And after surgery, usually we'll put like 3 or 4 stitches. That will be enough, because the incision not huge, only 3 or 4 stitches. You know, that's why people, you know, they are using more and more open surgery, because we know open surgery is effective with a minimal complication rate compared to endoscopic surgery. You know, endoscopic surgery, basically you are making a small incision on the side and put a knife to release a ligament. The benefit of this procedure is like an incision is small. But today, when people are doing the open surgery, the incision is not huge. So that's why people are using more and more open surgery to treat carpal tunnel surgery, to treat carpal tunnel syndrome. For postoperative care, I cannot understate the importance of elevating your hand above the heart after the surgery. You know, I always ask a patient, remember the first thing, keep your hand elevated. If you're walking, to wear a sling, to keep your hand above your heart. If you're sleeping, put a 2 or 3 pillow under your arm, because this is very important to control the edema, swelling. Also will increase the dose of narcotic pain medication. You know, it's not rare. A patient will call us, hey, I need more medication because I have lots of pain in my wrist after surgery. What did you do for my wrist? So we ask him, did you wear a sling? No, I did not. Did you put a hand elevated? No, I did not. So he's doing this like this, and he's taking like a tremendous amount of narcotics every day for 3 days. So it's a very important to remember for the patient to keep that hand elevated. Will help for the pain control, also help for the swelling, to relieve the swelling. You know, usually the dressing, we can take the dressing off in 3 to 4 days. The patient can do this at home. You know, usually we'll ask the patient to keep the hand dry and clean for 10 days, 7 to 10 days. Usually the patient will put a plastic bag, take a shower, and after that just put clean dressing on that. I think, you know, for the normal patient, probably it's okay. I think for the diabetic patient, it's a big deal, because they have very much higher risk to develop infection. So this is very important for diabetic patient. And also I encourage the patient to move your fingers after surgery, not the wrist, just move your fingers to prevent stiffness. And you can do some light activity, you can drink coffee, you know, you can brush your teeth, you can eat with the hand, just for light activity. You can take like prescribed medication as needed. Do not drive until you come back see us. You know, we do not encourage the patient to drive early or to lift heavy stuff over 1 to 2 pounds. You always ask the patient, just lift like half a gallon of milk, like 1 pound or 2, less than 2 pounds, until you come back, usually after 2 or 3 weeks. And expected recovery time and release to work or depend on the job. For example, if the patient works in the information desk in the hospital, you know, which require minimal range of motion of the wrist, then I will tell the patient, hey, you can go back to work in 3 or 4 or 5 days. This should be fine. If the patient, works in the furniture manufacturer, which require heavy lifting over 50 pounds, now I say you cannot go back to work until 3 months after surgery. So this will depend on your job. For therapy after surgery, I always refer the patient for hand therapy. Sometimes patients say, I'm pretty busy, I just don't have time to do therapy. They can just go to therapy to a couple of times, have some instruction or advice from therapists. They can do this at home. For the first couple of weeks after surgery, the patient is encouraged to do some gentle exercise and light use of the hand. And at 2 weeks, the patient will come back to our clinic to remove the suture. Then we'll start some active range of motion of the wrist, and also help to control the edema. Also, I ask the patient to get some vitamin E oil or cream, put it on the scar, and then do some deep massage, which can help to remodel the scar tissue. After 6 weeks, the patient can start a progressive strengthening exercise. Usually after 12 weeks, probably at least 90% or 95% of muscle strength, pinch or grip strength would be normal. So I think prevention, I think, is most important. It's more important than treatment for any disease. This is the same for carpal tunnel syndrome. This is just knowledge for everyone. Just take a quick break from repeated activities. You can rotate your wrist between these two hands, stretch your finger and stretch your palm, and you take the non-steroid anti-inflammatory medication to control the inflammation. And wear the splint at night, sometimes helpful. Do not sleep on your hand, because this could cause a problem. So here's some scenarios for prevention of carpal tunnel syndrome. Adjust your the height of the chair. Modify your position of your wrist. If you're a secretary, do some office work. And these are very, very important in ergonomic education. Correct position for driving, and stretch your finger, stretch your palm. These are very important. Wear the brace. I think most of the patient, if they pay attention to this little detail, actually the carpal tunnel syndrome could be prevented. So we know this carpal tunnel is most common syndrome in the upper extremity when we deal with the numbness and tingling in the hand. But do not forget Cubital tunnel syndrome. It's not rare. The patient has both carpal tunnel syndrome and Cubital tunnel syndrome. The patient will say, "Hey, I have numbness tingling on all my 5 fingers." Actually, they have both carpal tunnel syndrome and Cubital tunnel syndrome. Sometimes they can be treated with only wrist brace for carpal tunnel syndrome. They didn't pay much attention to the Cubital tunnel syndrome. Actually, could cause them even like a severe problem in the future. So do not forget, there's a chance for the Cubital tunnel syndrome. So Cubital tunnel syndrome is not as common as a carpal tunnel syndrome. The second most common. There are 75,000 cases every year in the United States. There's 1.5 million new cases in the world. I think in the general population, probably less than 1%. In the occupation requiring repetitive motion, it's about 5%. Remember, in carpal tunnel syndrome, in this population, maybe 15, 20, or 30%. It's much higher. But even though the 5% is still pretty high, for Cubital tunnel syndrome. Male usually male patients usually have like a much higher chance, 3 to 8 times, to suffer Cubital tunnel syndrome than female patients. For workers, requiring flexed elbow and a direct pressure on the ulnar nerve, usually they will have a higher risk to develop Cubital tunnel syndrome. So again, what is cubital tunnel? You know, cubital tunnel basically is a small space on the inside of the elbow. You know, from this picture you can see on the back side of the elbow, there's a tip of the on the back of the elbow we call olecranon. On the inside of the elbow, there's a prominence we call epicondyle. There's a space between these two prominences, and the diameter is about 4 millimeters. There's some fascia covering the space. And this is a space we call cubital tunnel area. So again, very similar to carpal tunnel syndrome. You know, the size of the ulnar nerve here is very small. It's about 6 square millimeters. There's about 10,000 fibers inside the little nerve. They're very small, very fragile. In terms of the mechanism, you know, we know the ulnar nerve goes behind your elbow joint. So every time when you flex the elbow, you can see from this picture, you know, you put a lots of traction on this ulnar nerve. You can see the ulnar nerve, and also some excursion. The shape of the tunnel also changed when you flex the elbow, which could be a problem. When you flex the elbow, the nerve can be displaced out from the tunnel, which will cause some constant friction and make the nerve susceptible to the trauma. So the fundamental mechanism is the same as that in the carpal tunnel syndrome. You know, increased pressure in the tunnel and cause some compression on the ulnar nerve. Then the patient will present some numbness, tingling in ulnar nerve distribution. This is what we call cubital tunnel syndrome. So let's talk about cubital tunnel syndrome. You know, you can see some numbness, tingling on a small finger. You can see on both sides. And also the patient sometimes they'll complain and say, hey, I just cannot feel anything in my small finger as the first symptoms when they came to our clinic. You know, very common patient will have some muscle atrophy inside of the forearm. The patient usually don't recognize it until we ask them put these two forearms together to compare that. The patient, oh yeah, I didn't realize it. Looks like one side muscle is smaller than the other side because the motor branch also involved. Patient will complain some clumsiness of the hand. The patient will say, hey, I cannot grab my little needle, or I cannot do a lot of small thing to put a button on, which I can do in the past. Later on, the patient can develop some muscle atrophy in the hand. You can see here also this tiny muscle, all this muscle severe atrophy. The patient also can develop some deformity. You know, they cannot extend the small and ring finger, which we call claw deformity. There's some risk factors I think it's very important for us to know. They are associated with the cubital tunnel syndrome. Elbow injury, you know, some patients they say, hey, you know, I had some fracture when I was very young, about 30 years ago, and I was doing okay. In the past 2 years, I still have some numbness, tingling, and they were diagnosed with the cubital tunnel syndrome. And we got X-ray and look at it. They had chronic deformity of the elbow from previous fracture. So elbow injury could be a problem. You know, rheumatoid arthritis, you know, could be a problem because the synovium or the deformity of the joint, repetitive motion, pulling, reaching, and a prolonged leaning on the elbow could be a problem. I'll show you some picture. And overuse or stress injury, you know, using vibrating tools, also very common. So here's some scenario in daily activity associated with the cubital tunnel syndrome. You can see you make a phone call on the table for like 40 minutes. Could be a problem. You know, you're doing some work at the computer like this, could be a problem. Some people just like to flex the elbow once they get a chance to laying on the table, which could be a problem too. When you drive, could be a problem because you're putting stress here on the nerve. When you're sleeping, and you sleep on the elbow. All this could be a problem to develop Cubital Tunnel syndrome. Sleeping habit actually is very critical. This is bad sleeping habit because she had the elbow extremely flexed. This is bad too. This is bad. This is bad. So I think this is very important. If you have a friend or you have a family member, they're sleeping like this, ask them, don't do this. Don't do this. Or just refer to me, I can tell them. So these are very, very important. This little thing can make a huge difference. How to diagnose the Cubital Tunnel syndrome, again, history is very important. They will have very classic numbness tingling in all of the distribution. You can see from here. Timing also is important. Patient will say, hey, I have numbness tingling if I flex the elbow for 10 minutes. Then I know this is a Cubital Tunnel syndrome. Physical exam definitely is important. You will see sensation change in all the nerve distribution. You have some muscle weakness. You will see some Tinel sign, means when you tap the inside of the elbow, you have some numbness tingling in the hand. Also, we call elbow flexion test. If you flex the elbow too long, you have some numbness tingling. Wartenberg sign, the patient they cannot close a small finger. Now, I still remember one time a patient came to our clinic. He said, hey, doc, I cannot put my hand into the pocket. My small finger always outside of my pocket. This is like this, because this is what we call a Wartenberg sign. And also there's another sign we call Fromm sign, because the patient cannot pinch a paper. This is normal side. This is an injured side. They cannot pinch a paper without bending these two joints. So this is similar to Carpal Tunnel syndrome. Sometimes we have to order X-ray to rule out arthritis and some pre-existing trauma to the elbow joint. We also order some electromyogram to test the muscle, and also we order some nerve conduction study to evaluate the nerve conduction speed and also stage the severity of the compression, also rule out other conditions in the cervical spine. So always started with non-surgical treatment. Start some non-steroid anti-inflammatory medication like Motrin. Sometimes we give a brace or splint. Actually, sometimes the patient can just use a big towel on the elbow joint to keep elbow bending, and also to modify the posture. This is very important. Such as the first case I present the case I present in the talk. The musician actually I asked him to just change your posture when you're playing guitar a little bit, and actually made a big difference. Big difference. Also, make more space between work and your hand, so keep your elbow a little bit straight. Do not keep your elbow bent for prolonged time. This is bad. So sometimes we have to offer surgical treatment because they failure to non-surgical treatment. The goal of the surgery is to relieve the compression of the ulnar nerve in the tunnel. The indication of surgery is clear, if you failure to non-surgical treatment. However, for timing of the surgery, this one is very different from the one for Carpal Tunnel syndrome, because for Carpal Tunnel syndrome, we can do the steroid injection over and over. For Cubital Tunnel syndrome, we cannot do the injection. Basically, the option for non-surgical treatment for Carpal Tunnel syndrome is very limited for Cubital Tunnel syndrome. If you're not doing well with the brace, if your symptoms keep progressing, and with the electrical evidence, then we probably just wait for surgery. We do not wait over and over until you have a significant muscle atrophy in the hand. We know this is bad. if you have muscle atrophy in your hand and you come to our clinic, then I have to tell you, we can help you with surgery. This will help you for the numbness tingling, but will not restore the muscle mass. Think about if it's a musician, they have muscle weakness in the hand. Basically, this is the end of their career. They cannot do this. So in terms of treatment, there's two types of treatment. One is the in situ release, one is we call it transposing nerve. In situ release, basically we just make small incision on the inside of the elbow. Actually, this incision is much bigger than the carpal tunnel surgery. We relieve all the constrictive band on the top of the nerve. The other one is anterior ulnar nerve transposition. We know the nerves on the back side of the elbow. We just need to move the nerve to the front side of the elbow. You can see from this picture, after you move the nerve, when you flex the elbow, you are not stretching the nerve. And for the anterior transposition, there's a couple of techniques here. This one we move the nerve from here to here, and sometimes we put the nerve under the muscle. Sometimes we put the nerve under the fascia. But in 2002, the data show there's no difference between these two techniques. Sometimes, if there's a bony prominence, we also need to remove that, which is important. So for the postoperative care, this will, I think, if we just release the nerve, which is pretty simple, like a carpal tunnel syndrome. If we put the nerve under the muscle or fascia, this will be a little bit more complicated. Sometimes we put the cast on the patient on the elbow, then change it to brace for a few more weeks. But anyway, you need to keep the incision dry and clean. Once the cast is removed, you start to change the dressing. You always encourage you to move your fingers, but keep your wrists in the neutral position. Do not stretch the elbow. And then you can start some strengthening after the splint is removed. And also we can do some scar massage. And after 6 weeks, we'll start some strengthening. So for the therapy, usually I have refer the patient to therapy all the time for the Cubital tunnel syndrome. They can have some protective splinting, also have some sleeve to protect the incision area. Also scar management, some swelling reduction techniques, and also desensitize the skin and active motion, including tendon and the nerve. And also some work conditioning activity was done like 6 weeks after surgery. So for the recovery, for Cubital tunnel syndrome, I think a large portion of numbness tingling will be relieved. And also the pain on the inside of the elbow will be relieved. However, the pain around the incision area could be like up to 4 to 6 months because of the scar tissue. And also sometimes the patient will complain some new numbness tingling on the back side of the elbow. Patient will say, hey, I did not have this numbness tingling before surgery. Then, we have to explain to them because to expose the nerve, we have to cut some little tiny branch to be able to see the nerve. That's why you have some numbness tingling on the back side of the elbow. Also, remember, if the patient have Cubital tunnel syndrome, usually we'll ask them to be very patient because the nerve regeneration takes 1 millimeter a day. Think about this nerve regeneration from here to here, 1 millimeter a day, 1 month, like 1 inch. Usually will take like a year, nerve regeneration from here to here. So another thing is very important. If the patient say, "Oh, I have the muscle atrophy," after surgery, am I going to recover? I say the answer is no. The muscle is gone; they will never come back. Ideally, you just come back early. Do not wait to that point. I think again, the prevention is most important. It's more important than the treatment. Avoid leaning the inside of the elbow on the desk. Avoid holding the elbow in flexion for too long. Minimize the repetition. Periodically take a break and slow down the activity using nice grip possible. Also use the least amount of force during the activity, because when you use too much force, you are stretching the fascia, cause some compression on the nerve. And also use ergonomically designed tools if possible. And alter the work activities between two hands. These little things are very, very important. Can make a huge, huge difference when you are doing this on a daily basis. So here's some scenarios to prevent Cubital Tunnel syndrome. Have you done 2 minutes?
We're over 500.
2 minutes.
Oh, okay.
Yep.
I just didn't want to.
Sorry.
No.
2 minutes will be finished. So here, you can put some pad under the elbow. You can put a towel around the elbow to prevent this bending the elbow. Let's go back to the case we presented in the beginning of the talk. So actually, he had numbness, tingling in the small finger. The diagnosis is Cubital Tunnel syndrome. It's not Carpal Tunnel syndrome. And he was advised to modify his activity and wear the brace at night, and modify his posture when he's playing the guitar. And after in 3 months, he did well. He come back to the clinic and was 100% recovered. And he brought a new CD to us with his new album. He was so happy because it's important. He said, "You saved my career." It was saying no more Cubital Tunnel syndrome, and he did well. He said, "I'll be very careful in the future for the posture." So, when we deal with the numbness, tingling in the hand, we also need to make sure we rule out other conditions. For example, here like diabetes or cervical spine problems, other problems, even heart disease, tumor. We have to be very careful. So here's a take-home message. If you have family member or have patient with hand numbness, tingling, when to act, pay attention ASAP. Do not wait. Who you need to see, you can see a family doctor, or you can see an orthopedist like us. What do you expect? If you can come to see us early, can be evaluated early. If you can be treated early, usually we'll do very well. You will do very well, and you are happy, and we are happy. Everyone's happy. So just come to early, see us. We're happy. We'll do the best for you. Thank you very much for your time. Thank you.